The information shared on the Allo podcast is not intended as medical advice. Your medical care decisions should be made in consultation with your physician who is familiar with your specific case.
Hi, welcome to Season 3 of the Allo podcast from the Allo Hope Foundation. I'm Bethany Weathersby.
And I'm Molly Sherwood, and I'm trying not to laugh. Because
Why?
I'm sorry, we're live and in color this time, and I'm very hyper aware of what my face is doing. So, hello, this is us. This is who we are.
Yeah,
This is us. We're wearing I'm wearing normal clothes. This is rare, so I hope everyone enjoys.
Yep, I am on my top half. I got my PJs on the bottom half, so
just
feeling relaxed,
staying true
ready
to
go.
Yeah, this is awesome.
And you guys can now see my wingspan that Molly loves so much. Actually, maybe you can't.
I don't think we have like a wide enough camera angle to really appreciate.
You're right. You're right. We didn't get the wide angle.
Yeah, we should have really busted it out.
Extra wide. Yep. Okay, so Season 3, we have so many great things to talk about, and we got through a lot of the nitty-gritty basic facts in Seasons 1 and 2. And so now our listeners have this wonderful foundation of understanding that we will keep referring back to and kind of build on throughout Season 3. And that knowledge base really does open up more room this season to explore some important topics together. And of course, continue to share patient and provider experiences.
Yeah. So, okay, let me just give a little tease of the things we're going to talk about this season. So this episode today actually was suggested as a joke from our producers. And so we were like, challenge accepted. And we're going to make it even harder. But they don't even know that yet. So we'll tell you about that in a minute. But then, special surprise for everyone. Next episode, episode 2, is going to be for moms with low antibody titers. And a quarter of allo pregnancies have titers that are staying below critical levels. And there's another portion that start off not critical, but then change to critical at some point in the pregnancy. So that's a big group of women affected by antibodies in pregnancy who we want to address specifically about their management. And honestly, seeing their stories, there are some consistent themes in there that we continue to see all allo moms share that we'll always make sure to speak on.
Yeah. And on the note of shared experiences, we're also going to keep on highlighting the global burden of this disease and sharing more patient experiences from all over the world. So we'll be looking at what do these patients have access to, and what does the disease care and prevention or lack of prevention and care really look like in developing countries. And I'm so excited because we're having Katie Shanahan on a few episodes coming up, and she is the director of development for the Allo Hope Foundation. And if you guys remember, we were able to spend time with her on episode 3 of season 2, and that's when she shared her story with us. And Katie and I were able to go to Kenya earlier this year with Dr. Moise, and it was such a profound experience. We all feel really compelled to share about the things that we saw there and the amazing people that we met. And so we're going to talk about that trip specifically, but also touch on an important aspect of this disease, which is prevention around the world. And then we also have an episode where we talk through management, not only in African countries, but also in countries all over the world, in other continents outside of the U.S.
Yes, I'm so glad we're getting to a place now where we can start sharing and pursuing our global intentions for the foundation, because even though we're in the U.S., I know that your goal from the beginning was to reach women affected by alloimmunization around the world, because numbers in other continents are much, much higher than our own in America, where we are.
Right.
So those episodes are going to be super important for our message. And let's see, we're also going to spend time talking about coping with anxiety during alloimmunized pregnancies. And another question we get a lot is how to continue to parent during an alloimmunized pregnancy and how that experience affects your parenting after having children. And so between me and you and Katie, we have like 9 living children and we still don't feel like experts. Yeah, it's a lot, but we'll just do our best with what we have slowly acquired painfully over time.
And a lot of boys too, right?
So many boys.
One girl in that whole group.
Oh my gosh. Yes. A lot of boys, like so much, just anything disgusting you could imagine. We've experienced
absolutely.
It many times.
Yep. Yeah.
And we also have two special episodes that include compilations of stories and just super profound experiences that allo moms have shared with us. And so we're going to be tying those into their own episodes, but then also incorporating patient stories that patients have shared into most of our episodes along the way. Okay. What am I forgetting now? What else?
Yeah. Okay. One thing that people have been asking us for is to make an episode for the family and friends of alloimmunized mothers so that they could get a really great introduction to the condition and then also learn how to best support the alloimmunized mother. And also, I'm super excited because we got a lot of great feedback about our episode last season with Dr. Kara Markham. And so we're bringing her back. Yes. And we're doing another Q&A episode with Dr. Markham. We're so excited. I can't wait for that.
That's gonna be awesome.
We also
love hanging out with her.
I know. That's the best part, is that we just get to hang with her.
Just hanging out.
And another thing is we've really been trying to focus more on the neonatal space to really turn our efforts and attention to proper treatment of HDFN in newborns. And so we recently met this amazing neonatologist, Dr. Tim Barr, and we love him. He's so knowledgeable about HDFN, and he is a neonatologist out of Intermountain Health in Salt Lake City, Utah. And so he's also joining us for a Q&A all about neonatal monitoring and treatment of HDFN.
Yes, super excited to have him. He's so wonderful, really compassionate, and just very invested in our disease. So that's going to be an awesome Q&A session. All right. I think that's all. That's our big teaser for this whole season 3. It took us a while to land on all that because we had so many things we wanted to do, but that's where we ended up. So it is what it is now. It is happening.
It's great. No, there's no is what it is. This is going to be incredible.
You're right.
Incredible.
That's right. It is good. I'm really excited about it. Okay, so today's topic. How did this even happen? I'm excited about this, but I can't remember how this became a producer's challenge.
Yeah, I think it was when we were just brainstorming about episode ideas, and we were trying to keep it short. We are trying to keep it short, right?
Yeah, always. We're so good.
Another
We're
thing,
just really good at keeping things really concise. Just straight to the facts. Nothing else at all.
Oh my goodness. Right. So our goal is to be more concise. And one of us just said, what if we just get straight to the point and we list the top 5 things that we think would keep the most HDFN babies safe. And so Eric, our producer, was like, absolutely not. There's no way you'll be able to share all 10 of those things and then keep it under 45 minutes. And so that's when we were like, absolutely, we'll be doing this now since you challenged us.
Definitely do that. Yeah, Eric, how are we doing so far on the time? Not good.
I mean, you're like 10 minutes in and you haven't really started the episode. So
we're just in the
I would
intro.
say you're off to a normal start.
Okay, we're on pace. By the way, Eric actually does legit radio and television voiceover stuff, unlike us. So thank you so much for gracing us with your angelic voice. Just lovely.
Yes, absolutely.
Okay, yes. And also I just want to say that we do have a shared script for every episode, but starting here, there is nothing written, and Bethany and I each took our own separate notes, except for, as of yesterday evening, we got ourselves really tripped up trying to come up with only 5 with only 5 things, because it's like, how do we list 5 things for both pregnancy and the neonatal period? So literally yesterday afternoon, we decided that we're actually going to each share 5 from the pregnancy management side and 5 neonatal things. So we're actually doubling the challenge, and now we're going to be sharing 20 things. And I'm literally informing Eric.
That is not Eric at all what we planned on.
Just doubling it up.
All right.
And keeping it concise at the same time.
Okay. Well, we'll double the studio time and everything.
Okay.
Too. Can we call
all
the...
Right.
Yeah.
We're going to do it.
All right.
Yeah,
so that means you have like a minute per thing now.
Correct. So
where
you're
before,
going to have...
I think we were planning on like 2.
Mm-hmm. Yeah. So does your voiceover voice do a really good, like, can you do one of those or something? Just keep things rolling.
I mean, it would actually hurt it. It's against my insurance policy. So we'll figure
you're
something out.
You're going to have to like get a bell or something. Yeah. Okay.
Oh, man.
We'll take care of it.
Okay. We're going to be concise and to the point. So these things are our opinions. Just keep that in mind. This is mine are my opinion. Molly's are her opinion. I can't talk.
Hers opinions.
Let me start that again.
Oh,
yes.
Great.
Okay.
Just carry on.
Oh, okay. We'll just say it. We're going to leave it in. All right. Yeah. So it sounds like August, my 3-year-old. That's how he talks. So Molly and I are not trained medical professionals. So we are not giving you exact medical advice for your specific situation. But we do think after years and years of seeing hundreds of these pregnancies play out and going through it ourselves and studying it for years, we think these are the 5 most important things prenatal, right, Molly? We're going to start with the prenatal
Okay,
list.
we'll do prenatal. All right. Pregnancy management.
Okay, we'll start with prenatal side. Yes, okay. 5 of the most important things parents and doctors can do to keep HDFN babies safe. And it was really tricky coming up with this list because care practices and access to care greatly varies depending on so many factors. It could just be location or even the provider. And so we don't know where everyone is starting. And so this is more of a perspective of the developed countries, I guess, typical care.
Yeah, we gave our caveat. These are our personal opinions. We may not even agree with each other. So, who's to say that all of our listeners will agree with all of our things, but we'll just do our best. So should we flip and I'm going to open up my page that I have on the things. Do you want to go first, Bethany?
All right, 5 minutes on the clock. Here we go.
Okay.
Oh, yes.
Okay, so Bethany's 5 things. Number 1, quick referral to MFM, and along with that, a list of MFMs around the globe who specialize in treating alloimmunized pregnancies.
Love it.
So, yeah, I think a lot of patients fall through the cracks between getting that antibody positive result and then getting to a qualified MFM. And the reason why I think the list is so great of the experts in treating alloimmunized pregnancies is because my dream is to have doctors around the world collaborating together on the management of this disease because it's rare and it's complex. And I just think that would be ideal. Okay, number 2.
Love it.
Preventative medications accessible to all women who need them. That would be great. And this includes anti-D immunoglobulin or RhoGAM to Rh-negative women when they need it. I think that would prevent
I love that.
so many cases of HDFN.
I would have added that too, for sure. But I was like, oh, is that... Anyway, can that be one of mine as well? Just saying that. It's not right now.
No, look, we don't really know what we're doing. So we're just going to accept everyone's
I didn't know we were including prevention. Fully in on that. Yes.
Well, but wait for it, okay? This is when I'm adding things together into one idea that's like 3 ideas. Okay.
Got it. Sorry.
So this also includes, it's okay. And these are technically not preventative medications, but we're going to roll with it. Okay. Plasmapheresis and IVIG for women who have a history of early onset severe disease or a loss or have incredibly high titers. Okay, so that's it. Number 2, preventative medications. Number 3, weekly accurate MCA scans starting at 16 to 17 weeks for those with critical titers or previously affected babies. And then for those who have had early onset severe disease and previously affected pregnancies or titers in the thousands, I think they should start at 14 to 15 weeks. That's ideal for me. Number 4, MFMs who collaborate with other experts and refer patients to more experienced providers when necessary.
Love it.
I don't know if there's any explanation needed for that. And number 5, IUTs performed on time using fetal paralytic meds by providers with ample experience performing IUTs who know how to space them and attempt to perform the last IUT at 34 to 35 weeks if possible. This is very specific.
It's so specific, but it's so, I mean, it's...
Is it too specific?
It's right. Like, that is... There's no count. I totally agree. This is great.
Yeah. I think the goal is just IUTs performed by providers who have experience and timed appropriately. Mm-hmm. That's it.
That's perfect. I love that. Because that's a different, like, that's a challenge too, is the timing of it.
Yeah. And that's also why the collaboration would be so beautiful for doctors to be talking about this. And I know that a lot of them do already. A lot of physicians do collaborate. But I think with rare disease, it's even more crucial to learn from each other and kind of support each other through this.
I agree with you, and I agree so
Molly?
much that I'm excited to share mine because you're going to laugh. I think. Okay.
Oh, okay.
This is great. I was really afraid that mine were going to be like way off base, but I actually see a lot of overlaps. Okay. Number 1 for me.
Okay.
Guess what? Immediate referral to an MFM after a positive antibody screen.
Yes.
Same as what you said.
Wow.
And, which is funny because I thought you were going to make fun of me for this because in a previous episode, I said in some very particular situations for a low titer pregnancy, it may not be necessary to refer immediately, but the circumstances in which that is reasonable and applicable are so minimal because so many women were seeing titers go nuts and then the women are scrambling to find a doctor. So does every single situation warrant this? Maybe not, but I think adopting this practice of an immediate referral and a high-risk team accepting that referral would potentially help with so many things, like figuring out the baby's antigen status faster, getting the mom IVIG and plasmapheresis on time if they're eligible, starting MCA scans early enough if the baby is very, very sick, because a lot of times the OB is not comfortable discerning what moms and what babies need to be seen immediately. So, which is understandable. They're not treating those patients all the time. So if we could just send them to an MFM, just send them, that would be great. I know you like that idea because you just said that.
I love it.
I know. Okay, number 2, weekly MCA scans. Ta-da! Same thing. I don't have to repeat. There it is. Weekly MCA scans for critical titer pregnancies. Okay. Number 3, which I think is along the same lines of something you said, but establishing global referral centers for IUTs. Stop sending moms to the nearest high-risk doctor by default. Every OB should know what MFM they're going to be sending to for this condition. And if it's very, very far, it's the patient's choice from there whether they can take on those logistical burdens. But let's stop assuming that the patient needs to go to the nearest high-risk doctor and establish a referral network. Like some European countries do that because it's also a little easier. They're Europe, smaller. But if we could have that globally, that would be huge.
Yes.
Okay. All
Love
right,
that
nice.
one.
Glad you're on board so far. Okay, the number 4 is more of like a concept, but I think it could really help, which is an awareness by both the patient and the provider that the seriousness of the disease can change at any time. Like low titers can jump up, first pregnancies can be severely affected. I think this would also make doctors draw titers consistently, even if they were initially low, or it will make them stay consistent on doing MCA scans, even if they previously looked good. Because if we just keep that in mind, that things can change on a dime, that would, I think, promote more close monitoring. What do you think about that?
Totally agree. Yes,
Okay.
that is so important to remember the timing of all of this management, the monitoring, the figuring out baby's antigen status, and starting the MCA scans, and the timing of the IUT after a high MOM, all of it, and the titers, delivery. The timing is very crucial.
Yeah, I think just having that in mind when a care team is making a plan would really result in very proactive monitoring. You know what I mean?
Yeah.
Okay.
Yeah.
Last one is a little general, and I know this is general advice to many pregnant moms, but go in if you notice a change in your baby's movement. We see this happening in terrible, tragic situations where the mom starts to notice that their baby is not moving as much, but they might be told, oh, you know, they're just getting big. It's totally normal. No, go in, get an MCA scan, get a non-stress test, and a BPP, and a BPP, biophysical profile. Check on the baby, see the baby, make sure the baby is really okay. If the mom has that sense, just check, because that really can make a difference, life or death. That's my last one.
Yeah.
Ta-da. We did it.
I love it. Can I add a thought to that last one?
Yes. Please.
Okay. You're like, yes. Please. Okay. Add more to our growing list.
No, we're doing good. Eric, how are we doing, by the way?
I think that
You're actually rather impressive. You're doing really well, actually.
Good.
Moving
So
along.
Bethany,
All
take
right.
all the time in the world.
I was even spotting Molly an extra minute because Bethany, you came in at 4 minutes. Molly, I was like, okay, we're time in 5. And I sidebarred CJ and I was like, no way, Molly makes it under 5 minutes.
This girl never.
And you did. I was even going to spot you. I was going to spot you an extra minute, a 6 there. And I'm impressed. Well done.
So now
Nice.
Bethany can
I'm
tell
gonna
me what
just
she thinks.
I'm going to fill in. Okay. I just wanted to add that I think that's also important for women to go in if they're concerned about their care for any reason, even if the baby's movements are not off or haven't lessened. We see a lot of women who are concerned because they're not getting weekly MCA scans, or they didn't like how high the last, MOM was, but it's hard to kind of bring that up and confront the doctor, or you feel like you're confronting the doctor, and it's just a battle of like, do I trust? But I think it's always best to just be careful and be proactive and go in and get checked, like you said. So I love that one. I'm so glad
love
you
that
thought of
addition.
that one.
That's so true. That's so true throughout.
Yeah.
Wow, we crushed that. Very proud of us.
We did. I do have 2 honorable mentions, and I'm not going to say anything extra about them, but can I just list them really quick?
Yes.
Number 1, honorable mention, referring all women with a positive antibody screen to the Allo Hope Foundation.
Oh yeah.
Love it. Okay. Number 2, delivering by 37 to 38 weeks, unless you know the baby is antigen negative.
That's really good.
Okay. I'm going to stop talking now about that.
I love those. Yes. I'm really glad you squeezed those honorably in there for honorable mention. Man.
Oh, it's so funny to hear the word squeezed and honorable together. I don't know why it doesn't seem to fit. It's just like,
yeah, it really
all
doesn't.
right.
It's just like, just nudge it in there. Just shove that in.
yeah.
All right.
With honor.
An
All right.
honorable squeeze. Yes.
Okay. We're spiraling into
We're
silliness.
spiraling into sleepover sessions.
Let's look at the neonatal management of HDFN and what are our top 5 most important things to remember. Molly, I want you to go first this time.
Oh, okay. All right, let me get back in my headspace. Okay. All right, Eric, are you ready? Ready for this? Okay, thumbs up. Cool. Establishing care in advance of delivery. And so I think the answer to that, I think the place where you establish care depends on the way that your disease has gone. But if you have needed some prenatal management, it looks like you might be headed for the NICU, you might be followed by peds hematology, asking your doctor to help facilitate an introduction to the neonatal team or the peds hematology team would be great. If so far things are looking really good and it's likely that you're going to be followed by a pediatrician, same there. Meet with the pediatrician and say, I'm likely to have a baby with HDFN, and bring resources with you to create the care plan with them, because so many times people give birth and then they just get plopped in the neonatal place after they've fought so tirelessly and advocated so hard during their pregnancy that they forget it's time to do the same now. So establish care in advance. You could bring the neonatal booklet from Allo Hope Foundation. There's a great publication by our wonderful friends in Leiden about neonatal management that we can link to in here. That would be awesome to hand to a doctor. Yes, stopping there. Okay. 2, create a fetal care record for your baby. This is something we've talked about doing for years at the foundation. Many HDFN babies are born with a medical history already, but it doesn't carry into their chart, especially this is an issue if the mom delivers somewhere other than when she received her treatment. So because the system isn't really set up for this, it might be on the patient to relay that care to the baby's providers. And we just created the fetal care record resource that we will link to. That would be a huge handy thing to have to help secure continuity of care. Okay, 3.
Good one.
Okay, I'm glad you like that one. Following bilirubin very closely. Are you laughing at me because I'm just like trying to plow through here?
No, I'm laughing because there's a slight delay in what you're saying and when I hear it. And so we just had some awkward moments where
Awkward spacing.
where I just butt in, but then you're still talking or like, yeah. Okay. That's
well,
all.
okay.
I was just laughing about that.
I'm very happy to be interrupted. Totally fine. Okay.
Okay.
Following bilirubin very closely after birth. Okay. And doing a trial 24 hours after coming off of lights before discharge. So Billy can rebound. We see a lot of babies that are sent home too fast because their care team took the baby off lights because the lights lowered their Billy. And then they were like, this is so great. Goodbye now. And then soon enough, 12 hours later, it's climbing back up and the baby needs to be treated again. Mm-hmm. So so the neonatal team should be really well versed in the American Academy of Pediatrics guidelines for management of hyperbilirubinemia. And that does involve testing quite often for our babies right when they're born. And not forgetting that the Billy can peak at days like 4 to 6 days old. So you got to be checking even daily through that part. What am I saying? 4 to 6 hours at birth. Anyway, just a lot. You got to check it a lot, okay? So just follow the guidelines. It'll be fine. Okay, number 4. Maybe you'll say that better if that's one of yours.
We'll find out.
Dun, dun, dun. Okay.
I don't think I'll say it better, though.
It's hard to say. Just check it a lot and follow the guidelines. It is. There you go.
Yeah.
Okay. Weekly hemoglobin or hematocrit after discharge. So when we're out of the woods in bilirubin world, we might still need to be checked for delayed onset anemia. And that could happen when the baby is several weeks old even. So having a plan where you're continuing to check hemoglobin or hematocrit, we say weekly, until it's consistently trending upward or stable in a healthy range for 2 weeks. Which leads me to my point 5, which is also more of like a conceptual thing. Follow the trend. Don't rely on one bilirubin reading or on one hemoglobin reading. That happens a lot where a mom contacts us and is like, this was their Billy, this was their hemoglobin. And that, of course, if one of those readings is not good, then intervention should be done. But If it looks good, you still need to know what direction it's heading. A trend requires 2 readings. So you want the Billy trending down even after 24 hours off of lights. And darn it. Okay, the last sentence.
Wow.
Hemoglobin hematocrit. That was a harsh buzz.
So
That was
jarring. I feel jarred out of my
mean,
mental space.
I know I invited you to do that, but that was like real harsh.
Wow.
Okay.
All right. We got the message, didn't we?
And then you want the hemoglobin increasing or at normal stable levels for 2 weeks. That's all. Goodbye. I'm done.
That was great. Okay.
Thank you.
Now I feel like I gotta really hurry.
Yeah, you don't
This
want to
is
hear that again.
intense.
That's intense.
Man,
Like...
all right. Wow. Well, okay, I agree with all of those. I love your phrase, follow the trend. I think that's something that needs to be implemented.
Follow that trend.
A lot of hours are the same. So just throwing it out there. So I'm just gonna blast through mine. Here we go. Okay, number 1, continuity of care from MFM to neonatologist to pediatrician to pediatric hematologist. And this means whoever's treating the patient, whether it's the doctor, the nurse, specialist, they all have the necessary information about the patient at the point of care. And this is tricky because the disease spans pregnancy, birth, and continues into infancy. And so I think that you had some really good tips with the fetal care record, and it also requires a lot of consistent and clear communication between MFM, well, all of those that I just list, the whole gamut of all of the providers. Okay. Number 2, test cord blood. Test cord blood, test cord blood. We think it's a given, but it's not. I think it's crucial to test the cord blood for hematocrit or hemoglobin, bilirubin, and a Coombs test at minimum. So, yeah. Okay.
Love it.
Number 3.
Was it a gong?
Yep. Okay. Providers. That was...
Was that you?
Oh my gosh.
Was that Eric and CJ?
The very tip of my fingernail, because I was flailing as I do when I talk. just barely tipped my mic stand, and it resonated loudly.
Oh, I thought that was like a 2-minute warning.
Like a gong. No, it was my fingernail just barely tapping this hollow metal mic stand. Okay. So, okay, number 3. This is also like a concept. So providers who understand how hemolytic jaundice and hemolytic anemia work and how they differ from typical newborn jaundice and iron deficiency anemia. I think that's a very common mix-up because they're seeing iron deficiency anemia and typical newborn jaundice far more often than they're going to see HDFN. And so I think it's important for them to know how aggressive the bilirubin can be, how quickly it can rise, how often it rebounds after lights are removed, and how it tends to peak on days 4 to 6 after birth. And it's also really crucial to understand that HDFN babies are at high risk for iron overload, even those who didn't have IUTs. So iron supplements can sometimes do more harm than good, and hemolytic anemia also can show up weeks after birth. And so these are the things that I think it's important for them to understand. And it is, again, it's a bit complicated because when the babies are out of their mother's womb, they still aren't away from the mother's antibodies, right? The antibodies are still in the baby's system for weeks after delivery. And so just understanding how it works. Which I hope that doesn't sound demeaning or something.
No, I feel like it's a lot of these things are concepts that then trickle into practice. And so we're just trying to bring it together to a concept level. Yeah.
Yeah. Okay. Number 4, really close monitoring and aggressive treatment for hyperbilirubinemia. I feel like I need to say that word again. Did I say that correctly?
I think you got it.
I did?
So
okay.
good.
So, all right, good. Basics, frequent bilirubin checks, aggressive phototherapy treatment, and IVIG infusions to prevent the need for exchange transfusion, and to prevent kernicterus. And number 5, follow-up blood tests weekly after hospital discharge, checking at the least the hemoglobin or hematocrit and the reticulocyte count. And then some still need to be looking at the bilirubin for a bit, just to be sure. But that careful management of the delayed onset hemolytic anemia is super important. That's it.
Wow, that was so
did
good.
it.
I feel like we nailed that. Minus me, I did get buzzed, but
I know.
I think we still did pretty good.
That's okay. I think we did amazing.
Yeah, I'm pretty impressed.
Yeah.
Oh, and one thing, well, I was going to say this, but I feel like you actually did cover the prevention piece. But I feel like it's worth pointing out that the number of babies that these tips would really help actually pales in comparison to the number of babies that could be saved through prevention altogether, like you brought up. And that would be with global access to Rh immune globulin, which some people call RhoGAM, or the anti-D injection. And so that's why we're dedicating a whole episode this season to the importance of RhoGAM. So I wanted to just point that out too when we're talking about the magnitude of this issue.
Yeah, absolutely. Okay, good reminder. And I'm excited about that episode coming up. And okay, how about let's wrap everything up and we'll put our 10 things each in the show notes and can we put some supporting references for those, Molly? Is that okay? Yes? Okay.
Let's make it long.
Eric is saying yes. Okay.
We might as well.
Thorough and long and researchy. All right. That sounds good.
Yeah, let's do that. And then do we have to just like abruptly end this to salvage the duration of this episode? How are we doing? Or should we just chat?
I don't know. Can we?
I really wasn't anticipating.
No, I think we need to go.
Okay, we should go. Okay. All right, well,
no, you can finish your thought.
I don't have one. I just
see. This is the awkward delay. We're just missing each other.
All right. Should I try I'm just going to try to just close us out. I'm just going to gently wrap a blanket around us with our closure.
Okay.
Statement.
I feel very comfortable right now. All right.
Good. Okay. Here we go. Whether you are a patient, provider, or, well, don't laugh.
I'm laughing at Eric's face. He looks disgusted.
It's like, ugh, warm blankets.
All
right.
Wrap a blanket.
Just stop talking, please. All right. He's like, oh, he's like, would you please? All right, here we go. Nice warm blanket of closure here. Whether you are a patient, provider, or otherwise affected by antibodies in pregnancy, we are here for you. We have great resources on our website at allohopefoundation.org. That's allo, spelled A-L-L-O, hopefoundation.org.
Thanks for listening.
Oh, yes. I was wondering which was going to say that.